There they go. Okay, Tanya, all the best. Thank you.
Hello, everyone. Hello. We're waiting a little bit for some people to join us. Hi, everyone. Good afternoon. So if you don't mind, I think I will start to welcome everyone, and then I will let our speakers to talk. So good afternoon, good morning, or good night. We're very happy to have you all for this webinar, the EAPC, European Association for Palliative Care webinar, again with our reference group, EAPC reference group on primary care. Today we're going to talk about the using of an instrument, a tool to identify people for palliative care, and we're going to see a perspective of 15 years of international developments. I will just share with you from the point of view of the APC, which I cannot see. So my message to you all is please interact with us as much as possible. We're very keen to hear from you, and yeah, I have it now. And please do not forget that this webinar will be recorded, and also you can interact using, you can translate your the slides that the presenters are showing. You can use these 3 slots and put it in your own language, and then also this is being slow. Please do not use your microphone or your video during this event, because it will be recorded. But then at the end, of course, we're very happy to hear from you. Please use the chat. Now, usually we have questions and answers also, but today we are incentivizing you to use the chat, and you can start in now. Please put your name and tell us where you are from, why you're here. We're very looking forward to hear from you. At the end, and during this, you will have a certificate of attendance, and we'll let the link in our chat as well. And also, we will ask you to evaluate the webinar, and we thank you all in advance. And that's it. Enjoy the webinar, and I will let Tanya Pastrana and Scott Murray to introduce you to this webinar.
Yeah, thank you very much, Carla, and thank you very much to all of you that you are here at this webinar. We are very excited because it is a great group that are speaking today, and this is a very central issue in the primary palliative care. I'm Tanya Pastrana. I'm co-chair of the reference group for primary palliative care, a group that Scott funded, and I'm really very thankful for all you, the speakers that agreed to be with us today. Scott, please.
Thank you very much indeed. It's great for everyone who's coming. Everyone is most welcome indeed, whether you're a member of the group or outside, and especially some people of the SPICT community who aren't so much in the EAPC, but they've been alerted, and a number of those are coming. And so it's really, I'll get it right on. I'll just introduce, and it's a real pleasure to introduce Kirsty Boyd. Kirsty, it was her idea to create the SPICT. She saw the need and carefully and meticulously over the last decade, or 2 in fact, developed and validated and helped help people in different countries to translate it. And now it's actually just now it's being translated in Chinese and Indian, and these will soon be on the website. So without further ado, Kirsty, thanks so much for coming and explaining to us the trajectory of the SPICT. Thank you so much.
Thank you, Scott. Can everyone, presume you can hear me all right. We'll just go to the first slide, and then I'm going to give you a little overview of like a potted history, if you like. And then we've got a fantastic panel from all across Europe, and we have one Nepali representative. And we'll just give you a little idea of how SPICT's actually working on the ground from those 5 different perspectives. It's been a true delight to be part of this community for so many years, and I get all your lovely messages through the contact us box, and I try to reply to you all and connect you up with each other. But it's a real community of practice, this. It's not just about a paper tool or a digital tool or a website. It's about the people who use this to help provide better palliative care for the patients we look after all around the world and their families and carers. So it's about giving the right care to people, not so much about a tool, but we are going to have a wee look at the tool. So if I could have the next slide, please. We're just going to run them through with somebody doing the slides. So this is right back to the beginning. So way back when the BMJ, which is well-known British journal, decided to do a poll around what people who read it thought was important. And the things that were voted top of the poll got a slot to produce articles in a supplement, and they were called spotlights. So Scott, who's being very modest, who is my partner in crime or my co-developer, and we wrote an article for this special supplement. And I dug it out and I had a little look at it. And here is a sentence or two from the very first thing we ever wrote, really, about doing this. And it's very interesting because now, doing 15 years on, looking at how we envisage palliative care and describe it, not much has changed. So it's still harder to work out when we should be introducing palliative care, offering it to people, than it is to work out, although that's not always easy, when someone is actually in the last days of their life. And interestingly, end-of-life care remains a contentious phrase, and I'm going to come back to that to the end. So that's the flag for later on. So at the very beginning, we had a look at what were people doing who were looking after patients with different conditions. How were they identifying people whose health was getting worse? And we looked at those. And then we looked at the general indicators that were across all of those groups. And surprisingly, they were quite common. So we divided them in 2, not very complicated. And we wrote the first ever issue. At that time, it wasn't called the SPICT, but the concept was there. So the same 3 questions are there now. The content has changed a bit, but the principles are unchanged. So this is not a numeric tool. It's not a score. It's a guide to you and your colleagues and all the other health and social care or care workers around the world who are looking after people, a nudge to think, is it time to introduce a palliative care approach alongside the other best available care that you're giving people? So we had performance status, we had weight loss, we had urgent care, we had being in a care home or a care unit, and we had those disease groups at the beginning. Next slide, please. So a few years on, we had actually begun to write something, and we were also doing work that you'll know of around the different illness trajectories or illness journeys that patients and families experience. And we conceptualized for 3 archetypical ones. But we also began to recognize that just limiting ourselves to looking at individual diseases probably wasn't the right thing to do. We were seeing people, yes, who were maybe diagnosed with cancer or perhaps motor neurone disease, a very specific, easy to identify condition. But we are also seeing more and more people whose health was just getting worse in general, or who were just older people, as we have across the world in many countries, an aging population. And this is my little car of what it's like to collect more illnesses as you go on your journey. So this was the next. We began to think more broadly and less in a way that was focused on diseases. Next slide. And this is just another way of showing that same thing. So you live well with your various long-term conditions, and then you start to have deteriorating health that fluctuates in a kind of unpredictable sort of way. You might get a new disease, you might get a complication of something you got already. You might just get a bit frailer and have an infection, and you dip up and down, and then at some point you would be dying, and we want to ensure that you die as well as possible. And it maps quite well to a tool that's part of a toolkit that was developed in Australia that a lot of people will know about, where you're stable stable, and then you're kind of unstable or deteriorating, and it's not quite sure which you are, and then you're dying. And palliative care needs to be part of all of those phases. Next, please. So this was the study that you'll have referenced, that was the kind of validation study, if you like, if there was such a thing. It is not, as I said, a numeric score, but what we did was we spent time going through a cohort of patients and we looked at mapping them against various other tools that were used at the time and to see what would happen to them. We followed them up to see who died and who didn't and what happened to these patients. And that helped us begin to provide an evidence base that has subsequently been extended, and you can see a list of the publications on the website, and if anyone's published anything, please send us it so we can put it up there. And at this time we're also, we still have our 3 groups, and these are some of the people who contributed to some of the research studies that we did and told us about their experiences. And at this time we're also beginning to see some shifts in the way cancer treatment's affecting people. There's more treatment options. People who would previously, certainly in more developed contexts, have had no treatment are beginning to get treatment, and that illness pathway is changing considerably. Next, please. So this is what we said at the beginning. Use it to help you in your practice. Use it to teach colleagues or students. Look at the people around you. Look at your most unstable ones. Have a think, is it time to introduce some palliative care? You could suggest, if you are perhaps not the person in charge, to suggest perhaps somebody else does a review. If you're a nurse and you want someone else to help you, or if you're feeling less experienced, you're more junior, say, well, I found these things in this person. How about we do a review? And we can use SPICT to open up conversations. And increasingly, as we'll hear later from Sarah, we can begin to think more broadly about how we use health records to do this too. Next one. So this was our first set of graph so we keep an eye on the website. We see whether you're visiting us or not and where you're coming from. So this was what had happened in that first 5-year period. As you can see, we got going quite small, and then we were hitting up to sort of 3,000 by 2018. And I'll show you the data from this month in a minute. So it was beginning to get going. Next one. So this is the surprise question, which is, we're often asked about the surprise question. So when we started way back 2010, surprise question was quite the thing, and it still is for some people. It's described in very many different ways. It's a bit like end of life. Are you just surprised if they die? Will you be surprised if they die in 6 months? Be surprised if they died in 12 months? And so that causes problems because people don't know what time period, and the time periods as I'm trying to suggest are actually very difficult to measure. And increasingly there's been evidence that using just pure clinician guesswork without any indicators or anything else to support that can be quite inaccurate. In fact, we're not that good at it. And in fact, we're not really interested in how long someone's going to live. We're interested in what needs they have and whether their illnesses are affecting their life such that we want to help them live better for however long that may be. So we no longer use the surprise question, although we did at the beginning as part of the SPICT. People sometimes use the two together, but increasingly we're moving on to looking at indication of burden of illness and the impact on quality of life. Next one. So this is what I mean about uncertainty. This was a large study where they asked health clinicians who were putting patients into a digital planning system to estimate how long they thought those patients would live for. And as you can see, they weren't too bad at working out who was close to dying. They were reasonable at working out who might live quite a long time, but this did not ask them whether those people needed palliative care or not. But they were pretty bad at working out whether people would die in the next month, 6 months, 9 months, that time of greater uncertainty as people move towards dying. And with the looking back lens, you can work it out, but looking forward, it is more unpredictable. So again, we're looking at accepting some uncertainty because it's inherent and embracing that and saying, you know, you have some signs you need some help. Let's see what we can do for you. What can we do? And because palliative care is all about doing things for and avoiding things that are not going to be helpful, but it's certainly not about stopping doing things that could be of benefit to people. And we also want to stop people waiting until they're absolutely sure this person's dying before they do anything, because you probably missed a huge period of time where someone could have had some form of palliative care and benefited greatly. Next one. Right, so I'm going to use, my current role is working on policy in Scotland, and we ask the policy analysts in Scotland to look at our registry data. We have quite good data in Scotland. What happened, what illnesses did people who died in Scotland as a sort of fairly archetypical developed country, what did they die with? Because that tells us what they probably lived with and meant that they might have needed palliative care. So I'm going to show you a few slides from that slide set. And this one shows you just how much of an aging population we have. And increasingly, we're providing palliative care, yes, across the age spectrum, but definitely for more older people. And we need to factor that into the way we think about how we do this. So as you can see, it's increasing greatest in the very old age group. Next one. So here we are. So we reckon around 90% of people have died with some sort of condition for which some form of palliative care could help them. And that may not mean a huge amount of palliative care. It certainly may not mean seeing a specialist. Could well be that your social worker or your GP or your community nurse or your care home worker would be the person that would provide that for you. But it's about looking at not the diseases that people have so much as the people who have the diseases and how we are the illnesses or the conditions. And again, the big flag up is two flags, older people and multimorbidity. And that's going to just get more and more. So more and more people will have multiple conditions which will interact with each other and cause that journey to be uncertain and quite difficult for them to navigate. The other thing that's interesting is some study, a big study that was done in the Republic of Ireland, where they worked out, actually following people over 50, that people living with various serious illnesses and palliative care needs outnumbered those in the last year of life by around 12 to 1. So this is not about necessarily just people in the last any time of life. Next one. So this is the data about multimorbidity. So what they did here was they looked at the 8 main causes of death that were registered. And so you can register a main cause of death and all the other relevant causes of death on our certificates. That's how it works. So that lets you count up all the different diseases that somebody's been living with before they die. And what's interesting is the pattern here. So if you can see that actually heart disease is top of the pops now, and it's increasing quickly. So we tend to think, oh, palliative care and cancer. I think we've moved on from that. We maybe think about palliative care and heart failure, but there's lots of other ways in which people might just have a heart attack on top of having, lung disease and cancer and frailty and suddenly die. And so cancer looks like it'll plateau out a little bit. I'll come back to cancer. Dementia, as we would expect, is continuing to increase. We'll be seeing a lot more patients who have mental health problems and cognitive impairment, and we're going to hear a little bit about mental health later on. And the vascular disease across the board is an issue and there's some work going on where palliative care is specifically being provided for people who are in vascular surgical services, where you might not give them an amputation, you might give them palliative care instead, which is perhaps an extension to what we would have done before. So we've got to look across all the diseases and the interactions between them and look at the person who has those different conditions. Next one. So this was have the next one, please. So the next 2 slides are from a BMJ special article that we were part of last year. And this is so we've now got the 4th trajectory. This is the multimorbidity trajectory. And many of you people here today contributed to the thinking behind this. So you've got all the different dimensions of holistic palliative care, all the 4 dimensions, and you've got this uncertain, wobbly trajectory where you can try and prepare for these events, and you can do that with planning, but you're going to have to provide urgent help and manage those changes as they happen and work with change and support people. So that was the kind of up and downy one of multimorbidity. And we'll just look quickly at the next one, which is the cancer one. So we could have that, please. So this shows that actually we used to have a kind of single one, the traditional one, the blue one in the middle was kind of how we did cancer in those days back when, not now. There's many more people who may die quickly with the complications either of their disease or their treatments. And there are people who will stabilize out, but maybe have long-term symptom problems. There'll still be people in some parts of the world who don't get treatment. And there'll be people in other parts of the world who get a huge amount of treatment. And accumulate more and more palliative care needs and more difficult decision making as that process of that illness evolves. So what was when is not now, it's different. And palliative care is part of cancer care in a different way from how it was 15 years ago. Next one. So this is our kind of working model at the moment. So we have long-term conditions, living longer with multimorbidity and frailty. Then we have palliative care. And one of the things we're starting to use the term is life-shortening conditions, because palliative care is not life-limiting. It does not limit your life when you have these conditions. It's about embracing living well. So we've decided to call them life-shortening rather than life-limiting. And it's for people of all ages. As we know, palliative care is for children too. And then you're going to have a final illness. And we've decided in Scotland to stop talking about end of life, because it's often used as a sort of euphemism for dying when someone's dying, or it's used for the last year of life, or it's used for who knows how long. And it's often linked very strongly with palliative care, which does us no good in terms of the public understanding, our patients and families understanding that we're not coming to help them die, we're coming to help them live until they die. So we're trying to talk a bit more now about care around dying. So when a person has their last illness, whatever that may be, we need to care for them through that time, care for them after they've died, and care for their family and the people close to them, have those people there and help those people through the bereavement that happens before someone dies and on afterwards. And future care planning, which is I'll come to in a minute, is a broader scope as well. It covers all these times. So we're looking for multiple illnesses before a last illness. We're accepting uncertainty, and we're identifying people for holistic review and future care planning until we recognize when they're dying, and then things shift. Okay, next one. So this is the kind of cyclical model of review that you're familiar with. So we need to use we can use different tools and triggers to identify people. We need to review them carefully. We need to look at all their holistic needs, as I've said. We need to make sure that we talk to them about treatment options. We say, what's the consequences of having that or not having that, or starting that or not having that? And what about your medicines? And particularly when you've got lots of conditions, you acquire lots of medicines, and us looking at avoiding what we call polypharmacy is good palliative care as well as managing symptoms, either by doing something about the disease or using good palliative measures. We need to make plans, we need to coordinate people's care by sharing those plans with them and others, and then we need to do it all over again when they have another of those dips. Okay, and good conversations are central to the whole thing. We need to be able to talk to people about what's happening and involve them. Next one. Right, so coming on to conversations of future care planning, which is the other thing that we spent a lot of time working on in parallel. So you might notice another word that's different. We're calling it future care planning quite deliberately to differentiate it from advanced care planning, because advanced care planning in many parts of the world is still seen as being a planning process that's for adults who have capacity and who wish to make plans ahead with the people who care for them. And I think what I'm trying to present to you and explain is the reason why that may not work awful well if you've got people who are young, if you've got people who have disabilities that might affect their ability to make those kind of decisions, if you have people who are old and have those things. So future care planning in our way of looking at it is for people, again, of all ages, whether or not they have capacity, because they've got other people around them who are their family, their friends, the people that know them, or the staff care team that know them, who can help together with them, hear what's important to them, and make plans together for what we might do if things change based on what their situation might be and what might happen to them. So you have some idea and you can make plans around that, and those plans can be shared with people who they maybe don't know or don't know them if they then have to have care, particularly in an emergency situation. And so future care planning is based on that kind of model. But in order to have those conversations, you need to have a bit of a framework to help you. It's a bit like all the ones we used to learn for breaking bad news. And it's about having the right people there and saying, this is about thinking ahead with you, helping you manage changes in your life, your health and your care. And let's do that together. And then finding out what people think, finding out what's important to them. And then sharing what we know and don't know, that's the uncertainty bit. And it's only when you get to number 4 that we're going to start number 5, that we're actually going to do the planning, because we need to find out, once we've understood their situation and they've understood it, we need to talk about what's important for them. Once they've understood their situation and what the reality of that is, then we can go, well, this is the things we can do. This won't work. What about that? If that happens again, and we can draw up a plan for if something might happen. So this is part now, you'll see if you're using any of the SPICT guides or the using SPICT ones, you'll see this little model is in there just as a little prompt of the kind of order and some of the phrases that you might use. And we call this red map. Next one. So this is up-to-date data, came off last month. Well, yes, we're not quite into, it's April, so we're not quite into next month. So as you can see, we've now got something like 172K of views. It's continuing to rise, and we're getting visitors to the various sites. So some people view the site, some people stay around a bit longer, but we're now well over 4 times where we were in 2017. So it's growing steadily all the time, the number of people that come to visit, which is great. And some of them some of them will just have a copy they pass to their friend, and we may not know that they're actually using the SPICT or visiting the site, or some people may not use the website at all, but this is the ones we can count. So I'll show you the next one. That's for the last year. And this is all the different countries. So there's some hotspots, sort of UK, as you might expect. Australia's big hotspot. And interestingly, we've had a real big hotspot in Brazil of late. There's been a new translation by some colleagues there that's been updated. And Brazil seems to be quite active at the moment. And these are the sites so people are still mainly using off the website anyway, are mainly using the SPICT. I think perhaps some of the other versions are being used more in other ways than that one. So you can see we're all around the world, a good international community. And I had an email yesterday from someone in Laos, which is my first one from there. So it's always good to get a new country and enjoy that. Right, next one. So this is just a little bit about the partners. So some of you have been partners a long time, and some of you have recently joined as partners. And so just to explain what we're doing with the partners, it was getting a bit confusing, to be honest. We had SPICT partners and we had platinum partners and we had 2 pages, and it was getting a little bit confusing. So what we've done, because we're doing a refresh of the whole site, because the program's going to be moving to being looked after by someone new soon. I'm not going, but we're going to have a transition to some new leadership. So we looked at all the partners and we decided to bring them all together. And so if you look at the site now, you'll see everybody's all together in one section. And you're listed under all your countries, and there's little entries for what everybody's doing. So we would ask you, if you're one of these partners, please have a wee look at your entry and contact us if it's out of date, or we've got the wrong link, or we've got something incorrect in there. Or if you would like to be a partner, do join us and come in. Some people who have particularly made contributions, given us some donations to help us run, because we're not for profit, we have no income source, or who have done particular work for us, we've given them platinum partner badges, a bit like. But these are some of our many partners, and so it's lovely to have you all. And there's many more translations actually on the way that we know about. There's at least another 15 groups that are working currently on translations. China, a lot from different Asian countries. We think there might be one from Russia. There's an Arabic one hopefully coming. There's lots of different ones from different countries of the different versions. Okay, next one. So here we are. So this is the 2025 version. And as you'll seen, we have tweaked it a little bit. The basic concepts, as you'll see, are not different from where we were in 2010. We still have general indicators of life-shortening conditions, and some prompts of viewing care and doing some care planning at the bottom. We still have cancer, we've got dementia and frailty in there. We've got neurological disease, and a more recent addition is stroke. That's an important group. We've got the heart vascular disease, and we've got other conditions. And one of the things that we're going to hear from Alice about is the importance of recognising how many people with severe mental illness often need palliative care, because they often have physical illnesses as well, and are a group that struggle to get care in general. So we've added that. We've added in about polypharmacy. We have just tweaked a few words here and there, and the other change being to using the term of life-shortening conditions. So that's the changes that we've made. They're very small, and if you're using a previous version, don't worry too much, update it when you can. and we're still doing the same principles of things. We're still asking for advice when we need it. And it might be a palliative care specialist you need. It might be somebody else. You might need an orthopedic surgeon to tell you what to do. You might need a physiotherapist to help you with breathing, or you might need someone else. So this is mostly about general palliative care, not identifying people for specialist palliative care, which is a different, more focused way of accessing expertise that needs to be around, so that if you need that help, you can get it from a colleague who's more trained to do so. So all of these new resources, those of you who are on the mailing list will have had the newsletter on Monday with the links. It's all up there, all free to download, as it always has been. So please go and have a wee look at our new versions. So we just have the next one. I'm nearly done. I hope to be on time and out the door. So we have 3 still main versions with these different colours, which we're keeping. So we have the original SPICT. We have SPICT for All, which started out life with some colleagues working in a care home who said the care workers here are really good at identifying people, but they don't understand your jargon. Can we write this in something that's more plain language, that's more accessible? And the SPICT for All has been really successful in lots of different countries and different settings. And we're particularly proud of our SPICT for All in prisons, which was developed by a group of prison staff who wanted to make sure that those people, and there's an aging prison population too with health problems, and they're people who generally have more health conditions. So there's a whole, at the bottom, if you look at SPICT for All, you will find SPICT for All in prisons with its guide, and you can use that too. And then obviously our one for lower income settings, which Dan, who's going to speak to you later, was the main agent in getting that going in Nepal. And we've also got most of these now in e-version, so you can click on that on your phone and it'll open straight on your phone if you don't want to use a PDF. We have kept the little SPICT record sheet for people who like to print them off and tick them, and some people do that, so we've kept that. So those are all on there for you to have a look at, download, share, use for your teaching or your research. Okay, final slide, please. So this is our nice familiar homepage with all our tablets, and that's this will remain. So as I say, we are looking at a move. The website will stay the same. The contact us will probably still come through to me, and a smaller team that look after the SPICT program. And if you're wanting to know what's going on, connect up with each other. It's a community. Find somebody else in another country near you. Ask each other questions. Share those things if you can with us. And if you publish anything, please do let us know. So yeah, somebody's posting. We'll deal with your questions in a minute. So there's lots of questions. So what we're doing is we're going to ask one of the team is looking at all your questions. I can't look at it sideways and look at my slides. We'll have a couple of questions now from the moderators, and then we'll have a bit more time at the end after the panel have all done their presentations, where we could have a bit more chat and questions and discussion. We'll keep the chat, and I will go through that later actually, because there may be some things that we can post in a newsletter or answer for you that way if we can't deal with it today. But anyway, thank you for listening and for being part of our program. Whether you've joined us last week or whether you've been with us from the beginning, you're most welcome. Thank you. That's me.
You can close, Nicole, the slide, the presentation. You are mute, Scott. You are mute. Thank you very much, Kirsten. I'm waiting that Scott open that mic. Scott?
Okay, thank you. Sorry about that. Thank you, Kirsty. That's a great presentation. Really appreciated that. Time's pressing on, so I won't take any questions just now of clarification. We'll keep them. But please, guys, I see there's people from all throughout the world, from Latin America to the Far East to Africa. Please put your name in there so we can see where you're from and if you're using the SPICT at all. That would be great. I'll just clarify, as Kirsty said, that SPICT isn't a tool for identifying people, who are going to die in 6 months or 12 months. It's not a prognostic tool. It's a tool to identify people with the palliative care needs. So just to clarify that one there. There will be more ideas about what the different versions look like as the presentations goes on, so we'll be able to get that there now. So next, I think I'll go ahead and introduce Sarah Mills. So if we could have that slide up, that would be great. I'm so pleased that she's with us today. Sarah, in fact, is from St Andrews University in Scotland. She's a family physician and leads a palliative care research team in primary care there. Subjects about she really is dedicated for improving palliative care in primary care. Now, she'll be helping Kirsty with ongoing developments and support for the SPICT. So we thought it'd be great for her to come today and just say a little bit about that and how the SPICT can be used in research and audit. Thank you so much.
Thanks, Scott, and thanks, Kirsty. And it's lovely to meet everybody. It's incredibly inspiring to see how many people are here from around the world. And I think for me, that really speaks to the heart of what SPICT is. Certainly, so SPICT was very timely for me. I graduated in 2010, and it was the first thing that I really got my teeth into in terms of palliative care, and I was utterly inspired by it. And primary palliative care has been a passion of mine. At the minute, we're looking at ways that we can improve identifying people who have palliative care needs, and particularly looking at inequalities within that. And it's very much feeds on from the lessons learned with SPICT. So next slide, please. I don't think I can advance the slides. There we go. So really the main challenge is identifying people. And whereas SPICT was very much sort of a nudge and a guide, we're looking at whether we can try to use health data science and machine learning, artificial intelligence to put in more of a gutter guard or a bit of a shove for clinicians to actually, try to pick up more people who have palliative care needs that are unidentified. We know at the minute it's about 50% of people who die are not being picked up for palliative care. Certainly in Scotland, there's an estimate that 20% of people who would benefit from palliative care don't receive it, and that 80% of people who die, should be in receipt of palliative care for varying degrees of time. And certainly, as Kirsty and Scott have said, it's about what your needs are, not necessarily how much time you have left. SPICT is an amazing tool for addressing inequalities, and I think the fact that we have so many people from so many different countries here really speaks to that as the heart of it. And one of the things that we know is that the more we move towards health data science, the less representative data tends to be. And actually, we have a very poor understanding of diversity and inclusivity within health data because it's often not captured or not recorded accurately or not used correctly. We're very privileged in Scotland to have the equalities and protected characteristics data set that looks at characteristics that are covered by the Equality Act 2010. So particularly with regards to religion, ethnicity, sexual orientation, anything that can make somebody part of a protected or minoritized community. And it takes census data as well as a lot of routinely collected health and social care data to try to identify those characteristics within people. And our team here is going to be using that in research for the first time in Scotland, actually, and trying to match that up with routinely collected healthcare data from the Unscheduled Care Data Mart to try to see if we can identify protected inequality characteristics as well as other clinical characteristics that put people at high risk of having unmet palliative care needs. We picked unscheduled care because actually it's very much sort of my favorite Willie Sutton quote is, why do you rob banks? Because that's where the money is. Well, why do we look at unscheduled care for people who have unmet palliative care needs? Because actually we know that they present to unscheduled care when those needs aren't met. And we know by work done in Edinburgh with Kirsty and Scott that actually the vast majority of people with palliative care needs will be presenting to unscheduled care within the last year of life, which again, palliative care not limited to that time, but we know that if we're looking at unscheduled care, we will pick up the majority of people. And by unscheduled care, in the UK, I mean the GP out of hours service, NHS 24, which is a phone-based service for healthcare advice out of hours, the emergency department, and the Scottish Ambulance Service. Next slide, please. So what we're doing is building a data set that includes demographic information, age, sex, rurality, deprivation, whether someone is a care home resident, what health board they're in, and their causes of death. We're looking at clinical primary care data, clinical secondary care data, so what diagnoses people are living with. We've got markers for what multimorbidity they have, what conditions they have, as well as what they die from, what they live with. And we're getting the unscheduled care data mart, which is data from all of the unscheduled care services. And we're linking that with the protected characteristics data set. And actually, if you look at the SPICT tool, there's a huge amount of overlap between the two. So actually the things that were put into the SPICT tool originally speak directly to the clinical information that we're looking at. Some of the predictive values that we're trying to generate. So we're making variables like, have you had more than 2 emergency department attendances in a given time period before current attendance? Those sort of things were first really documented in SPICT in terms of being predictors for palliative care needs. So we're looking at whether we can construct digital tools and markers that would be able to flag to us that whether or not people are high risk for palliative care needs. Next slide, please. And as part of that, we're working closely with the Fife Centre for Equalities, who are an amazing community organisation that is a link organisation to a lot of other community organisations that represent people with protected and marginalised characteristics, because we know that actually if we just try to recruit through healthcare, that we're never going to be successful in recruiting people who don't routinely access healthcare or who are underserved by the current structures of healthcare. So actually, we're going directly to community groups that are embedded within the protected and minoritized characteristics that we hope to serve with this. Part of what we hope to do in terms of generating a risk prediction tool is a numerical outcome, but actually one of the things that we want to do with our qualitative work is to speak to people in the community to try to determine what the best way of using this is. And it may be that actually the tool itself runs and gets a numerical outcome, but the patients don't want to know that they have an 82% chance of having unmet palliative care needs, that they'd rather just have a flag that goes to their clinicians that says this person's high risk, please do a review, that sort of thing. So looking at how we use such a tool, where we would use it, and whether it would be acceptable, and what the best way of implementing it would be for patients, and really making this a patient-led initiative. Next slide, please. And we're hoping that we can use the clinical risk prediction tool really just to flag to people's usual physicians that this person is actually in need of a palliative care review, so that they can put into place future care planning to address the needs that they have at that time and address needs that they may well have in future. Next slide, please. So really the aim is to enhance clinical decision making rather than replace it. We're not talking about trying to have robots that will tell someone that they're going to die. This is very much about supporting clinicians who are busier than ever, more overworked, less known to patients. We've lost the continuity of care that used to be that your regular family physician would be able to identify that you're declining and probably have palliative needs because they've known you well over the last few decades. That's very much gone, and people are often seeing doctors that they've never seen before in environments that they've never been in before, with relatively incomplete continuity of information and little continuity of care. We're also trying to improve not just how many people we pick up who have palliative care needs, but the timeliness with which we pick them up. So at the minute, we're the majority of people who are being identified for enhanced palliative care services are identified about 11 weeks before they die. And we're hoping that we can bring that much further forward so that we can start talking about palliative care proactively and not just in the last weeks of life, which again fits hugely with the SPICT mission. And we really want to make sure that there's a trigger of this identification process that then triggers future care planning and in a way that is proactive and responsive to patient needs and that fits within the current clinical systems and that we're able to deliver for patients and for their loved ones. Thank you.
Thank you so much for that, Sarah. That's great. That's detailed, and it gives us a good idea of how the SPICT can be used actually to inform the routinely collected data, which data is being collected. There. Great time. Thanks for more questions coming in. We'll have them later. Thank you very much, Sarah. That's great. Now we're going to go to Carlo Cardosa from Portugal. He's a member of our reference group. He's a family physician, lecturer in the Faculty of Medicine at the University of Coimbra, and is assisting others in the translation of tools such as the SPICT for all. There's a question about, is there a SPICT for people? There's just one, and we're going to hear something about that now and again later at the end. Thank you very much, Carlos. On you go.
Hello, everyone. Very nice to be here. Thank Yeah, can you hear me?
Yep.
I think so. Thank you all for being here and to get together to discuss this very interesting and important theme. Next slide, please. I'd like to share you some experience we have here in Portugal about SPICT for All. We all know this kind of problem or difficulty related with identification, not about prognosis, but about early identification. And first time I saw this SPICT for All tool, I thought, what about we place the identification in the community? And besides healthcare professionals identifying patients with palliative care needs, why not patients or families or caregivers or even neighbors to place the identification in the community? And this SPICT for All, this kind of translation to a more plain language of the first version of SPICT could be quite helpful. Next slide, please. So we conduct 2 master theses using SPICT for All. We try to assess acceptability, applicability, and try to use it in field, in primary care setting. We used SPICT for All, and we just check what could we find. Next slide, please. We asked some healthcare professionals to tell us what they think about the utilization of SPICT for All. I know it's for people not really or not necessarily being healthcare professionals, but we start asking healthcare professionals what do they think or what were their thoughts about SPICT for All. And I'd like to highlight 2 important questions. One about unassessed dimensions, and some professionals referred that visual impairment and hearing loss could be missing in this tool, and I thought this very interesting. And it seems that at least Portuguese primary healthcare professionals start to think a little bit broader about what are palliative care needs and what are patients with palliative care needs. And I would like to highlight this understandability point, because this tool intends to be easy to read and to understand by people which are not healthcare professionals. But some professionals thought that this might not be that easy, so we need to keep on doing some efforts and to study to reach or to find more easy to read versions of Portuguese SPICT for All. Next slide, please. But yeah, we also applied some tools to check how would be this instrument when someone assessed it or tried to use. And we find good reliability, good comprehensibility, a well-structured tool, and also a high percentage of actionability, suggesting that maybe this material could be effective in guiding readers, so patients, families, community, to identify patients with palliative care needs. Next slide, please. And then we try to apply it in primary care setting. We checked for 770 patient consultations in primary care, so routine consultations with family physicians, not scheduled by a specific need. And we found in this convenient sample 44 patients with palliative care needs, 6.6% of patients, which were not identified as having palliative care needs or not managed or being followed up by any other team different than family physicians. So this highlights that primary palliative care and primary palliative care in primary care is kind of mandatory. We really need to open this umbrella to reach more patients with palliative care needs. We found diagnosis related with cardiovascular disease, neurological disease, cancer, of course, but also dementia and frailty, which is very important and which is a hot topic. It's one of the conditions or disease contributing to important and unassessed palliative care needs. Also respiratory disease. So what we found is that this tool might also be useful to be applied in primary care setting and by healthcare professionals, because health literacy is not that high, at least here in Portugal, and palliative care literacy is also very low. So it's not odd to think that a tool with more plain language could also be useful for healthcare professionals. And now we just started, and the next point is to evaluate patients. We'll try to conduct this kind of qualitative study, presenting this SPICT for all to patients with and without palliative care needs, and try to keep on going with this development and improvement of the SPICT for all tool. This is it. This is what I would like to share with you, and I'll be very grateful to keep on with this chatting. Thank you so much.
Thanks so much, Carlos, for taking this SPICT for all. It really means SPICT for all. It's a bit of sort of fancy English. It's for everyone, for patients to use, carers to identify. Thank you for translating it into Portugal and then validating it and making you think about new conditions such as deafness and stuff like that. That was really exciting. Well done on that. Now I'll press on to introduce Dan Mundy now. Thank you. Next slide. From England and Nepal, in fact. Trained as a family doctor and a palliative medicine specialist, who spent the last decade in Nepal developing primary palliative care there. It's great to have Dan. Dan, thank you so much for speaking to your work there.
Unmute myself.
It comes now.
Okay, thanks very much, Scott. Thank you for the invitation to talk about Nepal. I'll talk generally about the work we're doing in Nepal and just some pointers about the SPICT LIS. We started developing this in 2017, having used SPICT. Actually, I used SPICT when I was working in the UK in the early days, working with Kirsty and Scott. And so we used it when we were doing a survey and found that actually there were some aspects that didn't really quite map very well in our low-income setting. So we first developed a Nepali version, and then Kirsty asked us to go on to see if we could do a more international version, which we did with people from India, Africa, Asia, and other places in 2017 and 18. So next slide, please. So Nepal, as most of you will know, is a Himalayan republic, very mountainous. It's low middle income. Most people live in rural areas. And there is a government health system with municipal hospitals, which aren't necessarily run by the government, but they can be registered for health insurance if they're not for profit. And they're often run by an MD in general practice, and then surrounding village health posts staffed by mid-level workers, sort of physicians' assistants. And the Nepal strategy for palliative care was developed back in 2017, and it sees these GPs and mid-level workers as key to palliative care. The GP should be the one to lead, both clinically face-to-face in the municipal hospital, but also in supporting the village health post workers. And we had the opportunity to run a project which is just finished for 3 years with UK aid funding to try and put this into practice with development and also research. So next slide, please. Nepal is very mountainous, we say, quite difficult to get from place to place, quite sparsely populated, which is why it really does need to take a primary palliative care approach, palliative care delivered by the healthcare workers who are there working in the community. Next slide. We'd been working with the Palliative Care Toolkit, which many of you will know. It's designed for low-income settings, and also is a very useful with sort of very simple treatments described, and also focusing on the sort of diseases that you get in low-income settings. Next slide, please. And we had the opportunity to translate the toolkit into Nepali. And so actually we translated the SPICT LIS into Nepali as well, and added that as another tool into the toolkit. And we found in our training that actually using SPICT LAS and using the toolkit together have been really, really helpful. Next slide. So this is the model that we've come up with, in the rural hospitals, patients are admitted and the doctors go around and see the patient, and they use SPICT LAS to identify those with palliative care needs. And we've actually laminated the SPICT LAS, and those are on the notes trolley so that they're readily accessible. And then the next thing is the doctor considers best available treatment. Now, this is one way that the SPICT LAS differs from the general SPICT, is that general SPICT has talked about optimal treatment, make sure that patients are having the best possible treatment. But actually, obviously, in a low-income setting, there might be things that you could do theoretically, but they're just not available from where they are for where you are. And also you have to consider the patient in terms of, how far would they have to travel? What sort of condition are they in? What's the chance of actually having a good response? So this best available treatment is something which we really, really very much emphasize when we're training. Palliative care isn't about stopping treatment. It's about looking at the patient in front of you and deciding what's the best possible treatment. And actually, we feel that in our setting, in the sort of primary palliative care setting in Nepal, it's not really possible to start palliative care too early. It's possible to start it too late. Actually, taking this approach where we're actually thinking what's the best treatment for a patient in front of us actually is good practice for any patient who you're dealing with. So that might be a bit of a controversial thing to say, but in the primary palliative care setting, we found that that's true. Then we have mid-level workers working in the hospitals who make an assessment, develop a problem list with the patient, and then with the doctor and with others in the team, they plan care. So that's the model that we've been using. And we've recently done a survey in 2 of our hospitals over 2 months, and found that 10% of the people admitted with SPICT, using SPICT LAS, had palliative care needs. And that's a fairly consistent figure from our previous work that we've been doing. And actually, we've used the palliative outcome scale to look at how people do during that time with the model too. So we find again SPICT and the palliative outcome scale work well together. And then the last slide, we've also, that's just to this isn't just a linear thing. We have to go back and review patients after we make a care plan. The next slide, final slide. We've used SPICT LAS in research to identify people, particularly using the general indicators. And this is a study we did in 4 different areas. And you can see the bottom line there. 2.5% of people we surveyed had palliative care needs. But then the box second to right, only 0.82% of patients had palliative care needs in this particular municipality. And this really reminds us that actually low-income setting countries aren't the same in every area. That actually we're trying to make sense of this, but actually this is a very low. This is an area with a very low human development index. And so you might have different levels of palliative care need in the population in different places. And really, you've got to think of your local population and what their needs are. So we found SPICT LAS very useful in research, and I know others have used it. I know that we've got Terry on the call from India who's used it actually retrospectively looking at data in India to identify the patients who have palliative care needs. So we found it very useful, and I'd really recommend it if you are working in a low-income setting, and try and improve it in your area as well. It can be adapted. It can be for your particular for your particular setting. So thank you.
Thank you so much, Dan. Thanks for rattling through that. That's great. So the SPICT can be used, ALIS, in a hospital setting as well. And it's been used quite a lot in Africa as well, even as a daily census to see the prevalence, if you want, of palliative care needed in a hospital at a point in time. Thank you so much for that. Right, next slide, please. So it's great that Simone has actually managed to get here. So Simone, sorry to hear that you haven't so well today. But I know we're a family physician from Italy, Masters in Palliative Care, Geriatric Medicine, and in the humanities. So you're a thinker. Passionate about the right of older people and migrants to receive palliative care. So tell us maybe about old people and care homes. Is it relevant there? There's a question about that. Thank you. Is Simone not here?
Simone, we can hear you.
Can you hear him, Tanya?
Yeah, also he's here, but I can hear him. Simone.
Right.
He's here.
No sign?
No sounds. Simone, can be that you are mute. Can you please unmute yourself? Oh, he's calling me in a moment.
Thank you. Thank you.
I can't, just a moment. Oh, now it's okay. Perfect. Yeah.
Thank you. Great.
Oh, sorry.
Simone.
I don't know what happened. Now you can hear me?
Yes.
Yeah,
I can hear you. Thank you for telling us something just in 4 or 5 minutes. That'd be lovely. Thank you so much.
Okay, we can go to the next slide. I will talk about the use of SPICT in a nursing home. Just the first overview about our project. We have national law since 2010 and in palliative care and pain relief in every setting, and we have basic palliative care doctors and specialized. But for nursing home, we have a big problem because generally nursing homes are quite isolated from the palliative care network, and our province try to collaborate with the nursing home using primary palliative care, especially general practitioner with special interest and the nurse dedicated in palliative care. As you know, nursing home has a very difficult setting because we have a lack of best practice. We have a lot of unmet palliative care needs. Also, we have healthcare professional turnover, and also a poor attitude in advanced care plan or future care planning. Our protocols now is published in our Italian Palliative Care Society. The next slide, please. Primary palliative care now following 53 nursing homes, quite all the nursing homes of our province. And of course, the problem was prognostic paralysis also for us. And we done some meetings with the doctors and palliative care unit to understand which kind of tools maybe we can use. And we decided to use SPICT, and we also still use the surprise question. After that, we make an online training, and it was successful with a lot of people connected online, but we think that online training is not sufficient to support nursing home. And also we perform on-site training. Each general practitioner and nurses come regularly in the nursing home, try to keep the project vital. Okay. Of course, our main goal is to provide palliative care for all. Next slide, please. And we have just 1 year and a half experience in SPICT. And after this first time, we wanted to ask the perception from the staff from the nursing home and also from the staff from primary palliative care if the SPICT is really a simple tool, is useful in early identification, and especially if these lead in advanced care plan or in future care plan. Well, we plan 12 questions and we have 55 responders. In the graphics, you can see that mainly are physicians, nurses, and also staff from the nursing home. Most of them receive palliative care training before our project, and most of them working in nursing home, and we have a good response from the setting that we want to explore. Next slide, please. And our results with the limits of questionnaire and survey that we know is that 80% use SPICT regularly, is for 76% it is an intuitive tool, but also we have a 23% that have difficulty to manage. I forgot to tell you that we use Italian version complete SPICT, not the other one. 43 consider that is well shared in the team, but for 56 is still challenging. 56 use for the for leading a care project. Of course, we have also the red data that we have to work on this. For 57, they think that is a good tool for early identification. 52 use it in the family discussion about the care planning, and 87 and more think that it could be also used in home care setting. And this is, I think, a very interesting feedback. Next slide, please. And final remarks. We have very limited data regarding population in residential home, especially in Italy. Also, the use of SPICT in residential home in Italy, we don't have, I think, lot of data. SPICT is becoming recognized, but few protocol, because for many nursing home nobody has protocols. We are a kind of virtual, a kind of best practice, but most of the nursing home doesn't have any kind of support. Potential value is extending the use of SPICT for different care settings, just for have the same tool. It could be a good way to communicate with also healthcare professionals, also for family and caregivers, I think. Our brief experience is really positive, but probably we think that SPICT is really easy. It isn't so easy. They need a training to understand, especially not all identification, but lead them to communication and in care planning. In this way, we can transform our support in real palliative action. This is my final remarks. Last question, last slide, sorry. Just I have to thanks to all the people that support this, because it isn't easy to maintain this kind of support without money and without human resources, but we try to keep it going. Of course, thanks to Scott and to all of you, because that you are inspiring my action in my place. I think this is very important for me. And also thanks to Anna Tusini for because she helped me in the survey and in collecting data in the presentation. If someone
thanks so much. That's tremendous, Simone. Thank you so much for, and it was the normal SPICT that I think you used. Yeah. And the question is, I'll leave it open. Maybe someone would like to volunteer to actually look at a SPICT for care homes or nursing homes. It may be more towards the SPICT for all one. but there's someone who's done that. And someone from Greece has actually said, we're looking forward to applying SPICT in primary care there as well, a new one. So thank you so much for that. Next slide, please. We go to our final panelist now, and it's Alice Johansen from Denmark. She's a team leader at the Knowledge Centre for Palliative Care in Copenhagen, and been working again with SPICT for All, and that is Alice we can see in the first slide. You're most welcome, Alice. Thank you.
Thank you so much. Hello from Denmark, and thank you so much for the great work in this reference group and for the great speeches. I'm pleased to share with you experience about how we in Copenhagen use SPICT for All to improve palliative care for all people needing palliative care, including people suffering from mental illnesses. Today, I'm speaking about mainly schizophrenia. Next slide, please. I'll just give you a very brief introduction to the Danish healthcare system according to understand how the Knowledge Centre can reach out and support the staff working with people suffering from mental illness. And due to large population in Copenhagen, we have two administrations, one for the Health and Care Administration and one for the Social Services. The experiences that I share today is from the social services, such as residential care homes for the disabled and the mentally ill. Next slide, please. According to Strengthening Palliative Care in Copenhagen, the Knowledge Centre for Palliative Care opened in August 2020. We are staffed by 4 palliative trained nurses, and we are offering palliative care hotline, courses and training, and right now we are working towards simulation-based teaching. We give outreach palliative team. We do support only, we don't take over the work, and we have a palliative network for healthcare professionals. In the beginning, we mainly trained and supported the staff in the health and care administration, such as nursing homes and home care. About 1 year ago, the Knowledge Centre was asked also to offer courses and training in palliative care for the staff working in the social services. As a team leader, I was concerned whether this centre had the right knowledge and competences in palliation to pass on to the staff working with people who are mentally ill or who are users of drugs and alcohol. Next slide, please. So the experience we have had so far by including staff from both the healthcare and social care in our courses, they can be summarized into 5 main topics. First, residential care homes for mentally ill are not normally staffed by healthcare workers. Most are social care workers called pedagogues, and this group of staff fear they have to take over the healthcare professionals' responsibilities. So by using SPICT for All, they gain qualification to identify problems earlier and seek help from the healthcare professionals. And second, social care workers find SPICT for All useful and relevant. As they say, people tend to have the same kind of problems. The difference is people with mental illness generally die 10 to 15 years earlier. Often people with mental illness is not diagnosed with physical illness due to anxiety, poor self-care, or lack of trust in the healthcare system. Third, a recovery approach is often used in social care. This actually becomes a barrier for the palliative approach. Staff are not trained to look for worsening of symptoms or physical illnesses. 4. SPICT for All helps identify the need for palliation long before we normally consider it. Normally it's discussed when end of life is very close. It is important to focus less upon the mental illness and focus more on the burden of symptoms. And 5. After an introduction, most staff find SPICT for All easy to use. The systematic approach is very much appreciated and helps them to communicate with the general practitioner in a clear and precise way. And last slide, please. So SPICT for All seems to make it easier for the staff in social care to recognize and talk about when a person's health is changing. It's all about the burden of symptoms, no matter the mental diagnosis. So for the last 10 months, we have offered training and courses for the staff in social services. My concern or assumption about lack of competences have been disappointed. What a relief. Thank you for your attention.
Thank you much. Thank you so much. That was great, Alice. Interesting. The SPICT for All is great, isn't it? Because it's allowing, access to palliative care support, and not restricted professionals, but for everyone. And that's the way we're going to manage to get everywhere. And your comments on mental health there. Thank you so much. Now, we're running a little bit late, but there's a number of questions come in, so maybe I could just shoot them. If everyone who's been in the panel, and Kirsty, if you open your microphones there, I'll keep them open. Now, Kirsty, I have a question here, straightforward. What's the difference between future care planning and ACP, advanced care planning? That could be a short answer, maybe.
Short answer is, if you look at the European definition, advanced care planning is for competent adults. Future care planning is for everyone of every age, and it involves the people close to them so that planning happens with the person and their network. It's also not focused on making a plan for a future situation, but letting people talk about what's important, helping them manage change in life, health and care. Because for some people, what might matter would be a legal process or something to do with their house, or what's going to happen to their dog when they get not well or have to go to hospital for treatment. So it has got a slightly different focus, and that's what we're now using here in Scotland.
And it's planning ahead. It's not just for
it's planning ahead. Yeah, it's
Yeah.
planning ahead. It's all helping people. It's the focus on people and the people close to them, helping them manage change, not us professionals moving in and tell them what they need to plan for. We need to ask them what's important.
Another one for you, Kirsty. Can the recently published Chinese SPICT be modified? Some parts may not reflect clinical realities. I know that you have a couple of teams there who started doing the SPICT in China.
So there are 3 publications at the moment, or 3 versions of the Chinese SPICT at the moment, done independently by 3 different groups, because it's a large country. And so this happens sometimes when there's different groups working in the same country, and we really encourage those groups, and we have done so with those groups. And I don't know if this colleague is one of them, is to get together and look at all 3 versions and then come back to us with a single version that we can put on the website as the agreed consensus version between you. If in doing that from all the groups there's some queries about something that's happening in China that isn't happening elsewhere, then by all means get in touch with us. But we've generally done that. We've worked with groups in countries and brought them together, and that's happening in Poland just now. There's, I think, 4 groups in Poland who are all working together, and they're going to produce a consensus Polish version, which we will then publish on the website with all their names because they've all contributed. So I
please, if you're thinking of doing something, let Kirsty know, and then you can maybe coordinate and collate that, and even support, because some of the secretarial work can be duplicated that way. So one other question: folk with severe disabilities, could that be a disease category?
Yes, so severe disabilities, as we've seen, could be everything from being deaf to somebody who's maybe born with severe congenital disabilities, a child who grows into an adult who then has many different complexities. So and somebody mentioned diabetes as well. The difficulty is you've only got 1 page. How many conditions do you list? And most of these situations, a bit like mental illness, you have multiple things. So we haven't listed disabilities. We could, but then the problem is you've got a whole range of disabilities and what's severe and what's not. So the other conditions category is about thinking about, is this person got some other conditions, but also some of these other things that make you think it's time to have a look at them. And this is all about the idea of how many indicators do you have to have. You could have one that's very severe and that's enough, or you could have several smaller ones. But it's the whole point of it is to have somebody bring that that assessment together, who looks at the person and thinks, is this time to have a review, to talk to them about something other than managing how we keep them well with their medicines or another treatment for their disease. So it does seem a bit vague, and that makes it harder for people to use. But sometimes it's about just gathering up the information, then having a team discussion about, well, they've got this, this, and this, should we do something? Or asking someone else, as we've seen from Alice's presentation, they've got this, this, and this, let's ask the GP.
Thanks very much. Dan, would you like to come in there, please? See if
Yes,
you have your hands up.
just on the sort of similar vein, really, we found in Nepal in our recent research that there are many people, particularly older people, don't have diagnoses. They it's expensive to go and get healthcare. They think, well, it's just I'm old, I'm getting frail. That's what you expect. And actually, the same as with the disability group, really, it's very difficult to have a catch-all clinical bit for those people. But I think if you're working in a low middle income country, just to be aware that actually people might have palliative care needs who haven't got and have got no chance really of having a formal diagnosis.
Yes, thank you. And we know a lot of people with advanced illness have serious, say, anxiety or depression can be there. So the question, maybe Alice could comment on this. Do you think this can be integrated in the SPICT there? Or should it, the question is what to do with that issue as well? Maybe SPICT for all, these issues are maybe more obvious for folk in the community.
Can you please repeat the question, because the sound here didn't come
Sorry,
through.
Alice, it's just another disability, if you want, is acute mental illness, maybe either itself or secondary to a diagnosis, or depression. Yeah. Do you think they appear well enough currently, and are they flagged up well enough in the SPICT just now?
Actually, we haven't done research. We are still working with experience so far because it's fairly new to include. But I think if we train the staff around, no matter what the diagnosis, we come much closer to giving qualified palliative care, because what the staff says, it's all about the general indicators. When they look at them, they find it easier to recognize worsening or decline.
Yes, thank you for that, because it's a sort of net psychological and physical and social and existential angst or distress, I suppose. That's what might trigger, the identification of someone for palliative care. Yeah. Tanya, are there any other questions that you've got there that you would like to share?
Scott, can I just come in on one question I see here that's come up and just to tag on to the last bit that what Alice said, so that she's right. So that's why in the general indicators we have people needing more care or support from either physical or mental health problems, because you're quite right, they may well be anxious or they may be physically more unwell and needing help. So it's a general indicator. There's questions in here about the surprise question, so we need to talk about that. And somebody else is asking, can you mix up the SPICT with the surprise question and the clinical frailty scale? So the surprise question, you can by all means use the surprise question or the double surprise question if you wish. And in fact, a colleague of ours, a GP in Australia, did just that. He combined the two, a surprise question and the SPICT indicators, and found that he could predict a bit better which patients should be identified. So by all means, if you wish to use it, our concern has been a focus in some places around trying to pigeonhole palliative care into a prognostic category and saying you get palliative care, you've got a certain amount of time to live, and that's not what we're trying to promote. But by all means, if you are happy using those tools alongside it, do that. The clinical frailty scale is interesting. It was developed in Canada more than 20 years ago. It's the one with the little pictures of people getting more frail. If you've used it, it's a picture thing. If that's the one you mean, the Rockwood scale. It is useful because it's got a good visual image of people getting frailer. Our problem with it is that the top score is 20 years out of date. It says if you have cancer and terminal illness with 6 months to go, you get the top score. So if you want to use it, perhaps just cross that one out, because it's probably not true nowadays. But sometimes people do find using a frailty tool alongside the SPICT, if it's a frail person you're looking at, is helpful. It doesn't really matter what you use. It's about using your using these things to help you make an assessment to, rather than having to get people into a category to, because we're talking about palliative care being integrated into the clinical care and the social care and the care that all these different settings and people provide.
Yes.
Not about going, you get something, you don't get something. So yes, by all means, use these other things if you know what you're doing with them and you know what their limitations are. Every tool has a limitation. So does the
Yes,
SPICT.
and geriatrics is a bigger, by far, specialty if you want than palliative care.
Yes.
So frailty is something that
That's
is
very
being
important.
evaluated more by people there. Thank you.
Yeah.
Now, colleagues, especially our panel members who haven't maybe spoken yet just now, are there any questions you would like to respond to? Or Tanya, anything in there you'd like to, we'd like to just, or just a comment, because we'll be finishing in about 4 minutes' time.
Well, I have a short comment, and it's something that I get from Kirsty and Scott with this SPICT, with this tool, because for me it was very important that they say this is not about the score, this is not about the question, it's about the mindset, is to think about the palliative care needs, and that, I think that is the more powerful for me from it's of course very powerful, but that is very, very important. And I have reading some questions about how to introduce it, how to introduce the medical doctor, how to introduce it in the community. And I think Dan can say something, and Carlos too, maybe, no? That's about it. Please.
Yes, SPICT can be more of an educational tool, rather than a clinical thing to fill in. It's just if you've got that mindset, maybe a surprise question is another thing that makes you think, but it's often thought as validating what someone's already doing. So that's good as well.
And
we haven't
needs,
mentioned,
and about the needs, not about the prognostic time, as Kirsty say now.
About the need, yes. Similarly, for some of the other tools like the prognostic, the PIG, if you want, and the NECPAL, these are all good because they actually bring this whole area to the agenda of serious illness and extra support.
I just say that in Nepal, in our context, we don't really get people to train for very long. We get, the doctors who we do train for 10 days, which is about the longest. But most people, it's just for a couple of days. And actually using the SPICT as the focus for that education and going through the different sort of aspects of it and continuing to go back to it through those 2 days really helps to sort of focus people in, and then they have something which they can really use, even if they've got sort of very, they've not had a lot of time in training. They can go and start using it in their practice. So we find that very useful.
Maybe make one more other comment. One of the other things we learn from people doing translations is, so when you do a translation, you get a group together and you get them talking about palliative care, because you start showing them this and you say, well, what does that mean to you? Think about some patients you saw last week, and you start generating interest in palliative care amongst a group of colleagues. So and I think Carlos is going to come in. I think he's a good example of that. Let you pick up on that, Carlos, please do.
I'd say about how to start using. We started with in nursing consultations. Here we work in team in our health centers and our family health units. Both GPs and nurses work together and in some complementarity. Some of the nurses didn't know about SPICT. So when I asked them, because those theses have more information, I just couldn't share all of it in 5 minutes. But when I first asked nurses, would you like to apply this tool? A little bit above 50% said that yes. But after they started applying the tool and they use it in house visit consultations or with some patients that came frequently to visit GP or nurse consultation, after 2 or 3 months, this score or their will to use this tool increased to almost 90%. So I would say a nice context to start using this in the community, at least here in Portugal, is to make nurses to use it, because they are sometimes here they visit frail people or people that cannot come to the health center at their home. So they have this gut feeling, there's something else that I can do with this patient, but sometimes they miss what can I do, or I don't know, maybe sometimes palliative care still generates some fear, but changing the prognosis mindset to there is something that we may need to address, I think is very helpful and strengthens the what healthcare professionals can provide. But I thought this very interesting.
Thanks so much, Carlos. That's great. So our time is actually just gone. So I think we should wind up right now. And maybe thanks, Simon and Sarah. Thanks for that. And maybe Tanya would like to just say something at the very end. But I'd just like, before that, I would just say there is an EAPC toolkit, and the SPICT is now integrated into that. So if you're wanting a broader overview of how we can best integrate palliative care into primary care, that I'd point you to the toolkit, again translated into 5 or 6 different languages, about policies, about education, and then service delivery. So that's a wee plug for that one. Tanya, thank you for allowing us to have this seminar at this webinar at the EAPC. Would you like just to close down? And Kirsty, if you want to say something as well too.
Yeah, Kirsty, please go ahead.
Okay, thank you very much. Word, I think.
Yep. I just say thank you to everyone for coming, for giving up your afternoon, evening or night and coming and joining us. We've really enjoyed having that sense of being a community around the world, and let's keep in touch and carry on doing what we need to do, which is get people to embrace palliative care. It's part of life as well as dying well. So thank you so much for joining us.
Ask for help with the SPICT or any tools like that, Kirsty and Sarah, as things goes forward.
Yeah. Well, and I thank you very much, the APC, Carla and Guillermo, for the organization, for the support, and you, all the speakers, because it was really, for me, a very, very interesting and exciting, very practice, like somebody said in the chat, webinar. It was fantastic. And please, if you want to join us, write an email to Nicole Foster. I wrote her email, and you can find us in the website. And it was especially important, this webinar, because it's a question of the participants to other webinars asking about how can we do that. And the identification is the first step for looking palliative care, for providing palliative care. And you are doing that. And really, thank you very much for all of you. And all participants that in this beautiful day, here is a beautiful day, are here with us. Somebody wrote that in Ireland is also a beautiful day. Also, thank you for being here. And I hope you join us at the Congress. We have an open session and we have a meeting together. We are very welcome. Please write an email and Nicole, and you can know more about this meeting.
So if you're coming to Helsinki, is what we're talking about. Hook up with us next month there. We'll have some good times together.
Yeah, exactly. Thank you very much, and see you soon. I hope so. And all the best with the use of the SPICT until Helsinki. Bye.
Bye. Goodbye, everyone. Thanks so much, everyone. Thank you.
Thank you. Bye.
Bye-bye.
Bye-bye.
Bye.
Thank you.
Good to meet Alice.
Yeah.
Dan, Sarah. Yeah. Kirsty, Carlos, thank you. Yeah. Simone. Thank you for coming. Simone's hand was up there. Hi, Tanya. Well done.
Thank you. No, thank you very much.
Wonder if Tanya is. I saw Simone at the end there. Just going to.
Yes, it is. Do you keep the recording and allow people